if you look at the science of cancer, we today know nutrition has a pivotal role to play. Every time a new technology is introduced, will your efficiency reduce because you'll have to adapt to a new learning. And that's where learning and training will actually change a new paradigm in VR, XR, MR, micro learnings to actually help you teach faster so that you don't reduce your proficiency but improve patient delivery. Technology will come closer to you faster than what you can even imagine. So we're not talking decades. We're going to talk days, weeks, months. I think in the coming time.
Hi, my name is Amara Mahendra, and I am the founder of Carer, India's first integrative oncology platform. In this episode, I am so excited to introduce you to a phenomenal surgical oncologist, the head of surgical oncology, HCG Hospitals, Dr. Vishal Rao. Dr. Vishal is extremely well recognized all over India and globally. He's an innovator, an inventor, and a dear friend. Every time I sit with Dr. Vishal Rao, I'm taken to a completely different orbit where we speak about incredible advancements in technology, only to find out a couple of years later that he has brought it to life. Dr. Vishal speaks about augmented reality, virtual reality, and all the advancements in clinical treatment for cancer. In this very first integrative oncology podcast being broadcasted all over India, we speak about healing cancer the right way and bring you experts from all domains to tell you exactly what you can do to heal cancer, prevent it, and cure the disease. Enjoy. Hi, Dr. Vishal. Thank you so much for being here. It's such a pleasure to again meet with you and talk with you. And I have a bunch of questions that I want to ask. But first, if you can start off a little bit about yourself. I'm sure the country already knows, but a quick introduction and then I'll jump into the questions.
Thank you, Samara. I'm Dr. Vishal Rao. I'm a surgical oncologist specializing in the field of head and neck. I'm currently the group director for head and neck surgical oncology at HCG, and I also wear an additional hat of being the Dean of Academics for the Center of Academic Research at HCG.
Great. Thank you so much for being here, Dr. Vishal. So I'm going to start off with prevention and screening. You obviously treat predominantly head and neck cancer cases, and a majority of that, if not most or all patients per se, is it's affected by smoking, chewing tobacco, alcohol, so on and so forth. So how do we battle this problem that is kind of self-inflicted? It's not really related to genetics, but it's completely lifestyle oriented. What can we do, of course, to bring these risks down? And those who are addicted to, say, chewing tobacco or even alcohol, how do we curb this?
So, Samara, I think the first thing to start with is, I think globally, if you look at it, head and neck oncology division need not exist. It's man-made. And it's one department where more than 90% of the contribution comes from a preventable cause and a significant contributor to non-communicable diseases, which is tobacco. Of late, we've also seen the rise of infections causing cancer. That is human papilloma virus, which is suddenly on the rise, leading to a small spike in the head and neck cancer, especially in the tonsils. I think which is something that of late globally we are acknowledging that earlier we knew viruses caused the cervical cancer, the human papilloma virus. Now we today know it's also a causative agent for tonsillar cancers and oropharyngeal cancers. And that's something that we are again looking at from a preventive point of view, where there's a lot of scope for working towards the HPV vaccines in the current point.
So, Dr. Vishal, what screening tools are there and measures that one can do? Because I can imagine it being quite frustrating for you as well as a doctor, because like you said, majority of these cases are preventable. So can you tell us a little bit about screening and prevention, and also the fact that many of these patients who come in and who are result in a positive malignancy go through treatment, and I know the treatment per se for head and neck is quite substantially difficult, and it's very impactful on any patient. But then they fall back into this lifestyle of smoking and chewing tobacco. So what do we do? How do we screen? How do we prevent? How do we keep our risks low?
See, the fundamental approaches in cancer prevention have been primary, secondary, or tertiary. Primary prevention focuses more on the aspects of policy related to things like tobacco control, control of alcohol, looking at vaccinations in cases of HPV and things like that, which is the primary prevention. The aspect of secondary prevention focuses on early detection, because even today we know that the biggest armamentarium in our support systems continues to be the aspect that if you are able to pick up the cancer early, you have won more than half the battle, because as a general concept, early cancers, that is early stage cancers, stage 1 and stage 2, require a one single modality treatment as a general rule. And stage 3 and 4 cancers require multi-modalities and have higher recurrences and greater failures. So the earlier you pick it up, the effort has been to look at trying to improve outcomes by picking it up early, rather than spending more after detecting it late and having poorer outcomes. So logically now, in the era of technology, a lot of drive is being given towards, can we pick up the cancer at stage 0, which is pre-malignant stage. And that's something that I think a lot of technology experts across globally are looking at from various scientific point of view of Raman spectroscopy or various other technologies to look at visual aids. Like we've got now narrowband imaging, contact endoscopy, many such technologies that have come that helps you pick up these cancers at stage 0, pre-malignant stage.
Right.
Now, this is a very important tool, but can be misused. For example, in thyroid cancers, globally data shows that unnecessary screening can be harmful.
Okay.
And this is something that people should understand, that when we talk about screening, there are certain cancers in which screening helps, and in certain cancers where screening does not help. So this has a lot of connotation for a general public to understand that, for example, if I'm talking about oral cancers, in oral cancers, what studies across the world with publications from places like Lancet and others and Cochrane and else have shown that in oral cancer, which is an aggressive cancer, early detection can be a magical tool. But if you use it population wide, the impact of that population wide intervention may not be anything great. However, if you refine your strategies towards high risk population, that is towards people who consume tobacco and alcohol, that would make the strategy of prevention and early detection, the secondary prevention, much more viable and much more logical, because you are actually getting a better outcome by screening the high risk population.
Okay.
In the same way, in places like thyroid or, for example, prostate cancers, there has been a debate about talking about, if you try to do an unnecessary screening, you are increasing the cost of healthcare, increasing the number of interventions, but the outcome has not changed. So, just to kind of give the audience a perspective, I'm giving you an example. There was a debate that happened in one of the political forums, where one of the senior political runners for a campaign made an announcement that, thank God that I'm getting treated in this country, because of which my outcomes are at 80% compared to the other country where the outcomes were only 60% for a particular cancer. Now, when he made this statement, the lot of the scientific world considered that statement to be wrong, because the way they pick up this particular cancer in his country was through a blood test, whereas the way they pick up the cancer in the other country was through symptoms. So the approach was two different things.
Okay.
So it's like me telling you that, imagine if let's say I'm developing the tumor. The tumor started to develop in my body at the age of 55, and I get detected at the age of 60 because of symptoms, and I die at 70. So I've lived a total of, from the time of the tumor starting, 15 years. Whereas if I use the blood test and if I pick up this person at much early stage, let's say at 56, but he still dies at 70, then what I've done is, this is called as a lead time bias. I have picked up the cancer much earlier, but the outcome has not really changed. He still dies at 70. However, statistically, I am adding about 4 years additionally to his life, which is what I'm saying, that is living for 14 years. This happens in low grade cancers. So the fundamental principles of screening should be used very diligently. Used indiscriminately, it can cause harm and not benefit, and can create more panic, can create more fear. However, we have to draw the thin red line of science to keep walking this path, to say that that does not mean to say that we'll forego and say screening is useless. Screening is absolutely important and is a very powerful tool when used diligently, and can help us plan and utilize our resources much better and give better outcomes and be more cost effective.
That's so interesting. I never actually viewed it that way at all. I just thought like mass screening, early detection, that's the answer. And wow, okay, I never really thought about it that way. But that's such an interesting point. Dr. Vishal, do you see that with families or you're treating patients who have got a malignancy because they are heavy smokers or they chew tobacco? Do you see this translating to other members of the family? Are they also at high risk?
So, Samara, this is a very relevant question. Often people ask me this. I tell them in a very categorical note that cancer is a genetic disease beyond a doubt. However, it is not a hereditary disease. There is a difference between a disease being genetic versus hereditary. Beyond the point, we have proven that cancer is a genetic disease. However, only 5% of these genetic cancers are hereditary. That means that through my life, through what I eat, through what I breathe, through the way I live, through my lifestyles, I acquire certain somatic mutations or genetic changes in my body, which are acquired through my lifetime. And that leads to a potential somatic mutation which can lead to cancer. That necessarily need not be transferred to the next progeny, because my genetic correction mechanisms and the DNA repair mechanisms are very good, and that's why it doesn't get transferred. So most of the cancers today fall in that category, that they are genetic but not hereditary. And so people should understand the difference between a genetic disease versus a hereditary disease.
But when you're in an environment or in a family where you have members of the family indulging in these various ways of actually increasing their risk, like smokers, it translates into other members being encouraged to do it. So, do you see that at all in when you treat patients? That and I meant in terms of just the whole environment that they are living in. Is there any kind of translation that happens over there?
I think beyond a doubt, we know, for example, tobacco is a carcinogen which has about 6,000 to 7,000 chemicals, of which 60 to 70 have known to be carcinogenic. Nickel, arsenic, chromium, cadmium, radioactive plutonium, benzopyrenes, formaldehydes, I can go on naming them. There are so many chemicals. Now, when a person consumes these, it has been told that the passive smoking is more dangerous than active smoking. Why? Because when a person consumes cigarette, there is a filter attached to the edge of the cigarette with which he inhales the smoke, whereas the other end of the cigarette is an open ended one where the direct combustion of the tobacco is happening without filter of any of these chemicals. So the passive smoker somewhere inhales both the active and the unfiltered smoke, and the other passive smoke which is being exhaled by the person's lungs. So today, in a closed environment, people are talking about not just second hand smoking, they're talking about third hand smoking. That means in that area of the restaurant, hotel, or your homes, the smoke and the carcinogens that are there could actually be sitting on your clothing, on the upholstery, or on the food items, and could be there for a very, very long time. and could equally be harmful. So beyond a doubt today we know that secondhand smoking and passive smoking has is a high risk factor, a risk factor for various diseases.
My gosh. Okay. And I have to ask you this, Dr. Vishal, because I know you work with you'll work with multiple state governments as well as reputed international forums and regulatory bodies. We all know smoking is bad for us. I think on a government level, they have put pictures on cigarette packets and so on and so forth and done whatever they can. But do you feel like you're fighting an uphill battle when you're trying to educate or bring some knowledge to the general population of the fact that this leads to cancer? Because it's all known, but is there really a change that's happening because of the education, or how do you fight this battle?
So I think the fundamental battle has been with regarding to pro health and not anti tobacco. While tobacco is a very systematic industry that I think has evolved over decades and centuries and been a part of culture and tradition, the actual game is on the nicotine business, not of the tobacco business. Now, if you understand this and if you understand the business statistics of and the tactics of the tobacco industry, India, I'm giving you an average, we lose about 10 lakh people or 1 million people to tobacco each year in this country because of cancer, lung diseases, heart diseases. Now, putting these together, and every state government spending about 1,000 crores, or nearly 1,000 crores per year on these diseases, three diseases. Prevention seems to be a logical answer. However, the nicotine business runs in a very systematic way because we know that the industry runs the nicotine business and not the tobacco business. And in this way, nicotine is the most powerful addictive substance known to humankind. It is more powerful than heroin and cocaine. In fact, 90% of the drug addicts begin with tobacco. So it is also a gateway to drugs. And tobacco is a very potent addictive agent. And that's why the tobacco industry's formula is that every year, I mean, I'm talking if you are a businessman and I lose 10 lakh customers each year, I need to get back 10 lakh customers each year, logically, if I have to continue my business. Correct? Now, how do I get that at my age group or at your age group? I don't think we are in a position to start a new habit because our brain has already adapted itself to certain neurons. And you know how difficult it is to change the way we live today or the way we eat today. It's so difficult. Starting a new habit becomes very complex. So the industry has always been targeting on the youth. And they know the critical number that it is only at that critical age group between 10 to 18 that you're the most vulnerable and you will be able to start new habits, and which is why the target of the industry has been to influence young minds. For example, I was watching a movie where the detective, before he thinks and before he has to come up with a solution to solve the crime, had to smoke a cigarette. Or the lady, before she had to express the sexuality, would take a cigarette and smoke. This has positive affirmations and influences on the youth to adapt a particular habit. And this kind of approaches would actually help you think that I can, it increases the peer pressure on you to adopt a habit. Now, what also the industry knows is if we give 100 people a cigarette to smoke or a tobacco product to smoke, only 30 of them will be your long term consumers. And that's why the the industry's connoisseurs would work towards adding as many chemicals into this to improve the nicotine delivery mechanism by which you are able to maximize the addictive power of nicotine for a long lasting period to get the person hooked to this habit so that it doesn't come out. So on a lighter note, I keep telling people that the willpower is is lesser than will's power, and it's complicated. It's not easy to come out of the nicotine habit to the paradoxical extent that some of the world's top tobacco companies run their own de-addiction program. They are so confident that you can't come out of it.
Oh my gosh. Wow. Wow. Okay. So what happens now when there is, and this is going into, treating a malignancy, and you're dealing with these cases on an everyday basis. I think to me and the country, you are an innovator. You're always ahead of the curve in terms of medical advancements and treatment. What are some of the things that you can talk about, Dr. Vishal, that has been profound in the recent times in terms of treatment of head and neck cancers?
I think the most interesting and inspiring fact today would be that we have shifted our focus to a great extent in thinking, where we earlier thought that stage 4 cancer was end life, palliative, to now talking about cures in them and remissions in them. I think that's the biggest shift that has happened, and I'm kind of drifted to some of the old discussions that I would do. That Judah Falkman, one of the earlier father of angiogenesis, would often quote and say that there would be a time in history when we will coexist, when the cancer cell and the immune cells and the normal cells will coexist in a harmonious ecosystem without killing each other. Because today we've been talking more about fighting the cancer and not healing the cancer. So I think there is going to be a shift in the coming decades towards how can we optimize and accelerate healing of the body by understanding the interplay between the cancer cell and the body's own immune cells, and that would actually set the platform for talking about coexistence beyond cure, and not just eliminating tumors through only the three artilleries that we use today: surgery, chemo, radio, and look beyond these particular approaches to adopt new strategies which has more participation from patients, which is more having a more involving 360 approach from patients in a holistic manner that talks about activating the immune system along with controlling the cancer cell. And that kind of an approach is what the world is heading towards in immunotherapy. And I think the next 10 years will be for synthetic biology. I myself been a part of several of these committees, both in the state and the union government, working towards synthetic biology. And I believe, and I encourage my youngster colleagues to adopt the surgeon scientist program or the clinical scientist program, because I believe that that is going to be the future. That the next 10 years, and you can maybe replay this a decade later and tell me whether this was true, that the surgeon's role will also be to spend time in the lab looking at genomics, proteomics, metabolomics, uh, multiomics, and microbiomics. This is going to happen. And that would be crucial because you would know more amount of the genetic signatures of tumors. And what we are seeing evolve in today's paradigm is the future evolving in synthetic biology seems to be rapidly accelerated. Where for a common man, what is synthetic biology today? Thousands of crores is being invested by the states and union governments in synthetic biology today, because this is that aspect of science which teaches a cell a function it does not know to do or has forgotten to do. So, giving you a simple picture, in HCG, between my three towers, I have one genomics lab, I have a surgical wing, I have a immunology lab. So, when I'm operating and taking out a tumor, one piece of the tissue goes for the genetic analysis, another piece of tissue goes for immunological analysis to the synthetic biology lab, where the patient's few ml of blood in a petri dish inside a clean chamber, which is as clean like your human body, is asked to meet your tumor cells, and they both are interacting with each other in a controlled environment.
My gosh. Okay.
And in this environment, they both are actually getting trained, where the immune cells are being trained to teach the immune cells on how to stop these cancer cells from growing, because they somewhere inside the body were not able to learn it. So, an external training is provided through super antigens and looking at non self antigen simulations, where the cancer cells are outside the body, teaching the normal immune cells on how to pick them up. And then you take that small quantity of blood immune cells, which have already learnt it, and multiply them using plasmapheresis, like a Xerox machine, into thousands and thousands of cells, and reinfuse them into the patient's own blood.
Wow.
Now, I'm saying this is not sci fi, this is happening as we speak today. This is not something that's going to happen tomorrow.
And this is what you mean by coexisting, right? So you're not necessarily going in there and destroying the cancer cells, but you are enhancing the immune cells and then allowing the cancer cells to just kind of survive along and coexist. Is that what's happening?
Absolutely. And today, if you hear, sometime back there was this big buzz about this particular drug which from
Yes.
USA that made a thing that all of them got cured. What was it? What did that drug do actually? That drug actually was able to work on specifically reprogramming the cell through engineering and activating the normal cells, not killing the cancer cells. And
Right.
that is what immunotherapy is about,
Right.
to focus on activating this immune system. And that's one aspect of synthetic biology. And the second aspect that I would like to touch here is the advent of big data with small data. Now, the small data is what I'm talking about is genetics, genomics, wherein one small tissue of one patient will be delivered for personalized medicine, and the big data will give you more of precision medicine, which will be able to tell you in a combination of how we are going to be able to target using big data, AI, system learning. Now, there are four stages of AI. We have reactive AI. We have, after that, the limited memory AI. Then we have theory of mind and self aware AI. I remember one of my lectures that I was giving as a keynote address in 2019 end. I was talking about the future of AI, where I said reactive machines have already come in. You're hearing about Alexa, Siri, and we're slowly moving in towards the driverless car. And mind you, this was in end of 2019, just before the pandemic hit, when Elon Musk is talking about driverless cars, which have already entered the market. Two, I was telling Stephen Hawking was worried about theory of mind and self-aware AI. Now I'm saying, just a couple of days back, I've just read that one of the engineers from Google was able to reach the self-aware, the theory of mind concept, and able to show it. So what I thought would happen 10 years later in my keynote talk when I was talking happened 3 years later.
Wow.
And of which 2 years was the pandemic. So I believe that the acceleration of technologies will be much faster and at such a rocket pace that it may be difficult for medical fraternity to adopt sometimes, and it will be scary. So, there's a good debate to say that every time a new technology is introduced, will your efficiency reduce because you'll have to adapt to a new learning. And that's where learning and training will actually change a new paradigm in VR, XR, MR, micro learnings to actually help you teach faster so that you don't reduce your proficiency but improve patient delivery outcomes in a comprehensive.
Wow, Dr. Vishal, I didn't know that. That's so interesting. My gosh. So I'm going to go into a very interesting topic that you actually introduced me to, which is augmented reality, virtual reality for management of cancer symptoms, of psychological distresses of a cancer patient, for pain management. I know you are deeply involved in this, and like I said, you're a visionary in this kind of space. So, would love to know where you are, what you're doing, and a little bit more about that.
This all started with one of my inventions on extended reality that I had actually created and patented, and that's when I actually started working on understanding this, because I realized that in one of the early, I would say, 2017 in Mumbai, we had a national conference on virtual reality where many people from across the world, and I was one of the only few people in the healthcare domains who was talking there. This is way earlier at that time, and we were at that time talking about augmented reality.
Hmm.
Now, the space of augmented reality, starting from virtual reality and now going to extended reality and mixed realities, has been an evolving spectrum. If you ask me today, let's simplify this and say, let's not complicate the world to saying, oh, this is cool tech. I'm asking you today, as a surgeon, I remember 8 years back when my chairman asked me saying take up robotic surgery. I said I'm very happy. I don't want to do this robotic surgeries. I don't want to learn it. Two, spending some time in training in augmented reality in this particular area and feeling that I could actually learn this much faster, and slowly moving towards the area of training and understanding and doing robotic surgeries. One of the most simplest things that I understood was, I sit in a room today, or you take your room for example, and if you take an image of this on our phone, the image looks better than that of the real thing. And that is what optics has done to us in terms of making an experience more real, more interactive. So it is instant, it is interactive also. And in this particular process of being instant, interactive, I think it kind of gives you a very comprehensive, immersive feel. So you take the three I's into this: instant, immersive, and interactive. You actually are built into an ecosystem where you are able to experience the structures better. So, in a simple way, I say in robotics, I have, as a surgeon, small eyes and big hands, whereas the robot has small hands and big eyes. So, it actually helps me go to places where I would normally not go.
Right.
And augmented reality, mixed realities has been able to bridge this kind of a gap for us. Some time back, we did some very nice programs with Microsoft, wherein with the HoloLens, we were able to look at, I would not say technically teleportation, but something close to that experience, like in Star Trek, where I was able to go to my surgeon friend in Mysore, just like what I'm sitting in front of you, Samara. I was able to visit my friend in Mysore, and he was actually seeing my 2D avatar, or what you call my virtual presence, sitting on the patient's right shoulder and watching to millimeter precision the entire surgery and talking, interacting to him, talking about specific steps, exchanging notes on what are the areas of concerns, and adopting. And that is what technology has done to us. I think the point here is technology is an assistive tool. It is going to accelerate, augment, and accentuate human healing. It is not a replacement for human hands, but you cannot say that the healing touch could be replaced by haptics. It cannot be, but nonetheless, it still can be an extended arm to assist you to treat the patients better and minimize errors.
How far do you think we are away from it becoming mainstream in treatment of cancer?
We are already seeing its adoption increasing, and we are building use cases for patients, hospitals, and doctors. Three separate verticals. Hospitals have already started creating their own meta avatars wherein you can come and tour the hospitals. Doctors have started using this for better treatment planning already in a more immersive environment. And patients, I remember distinctly two patients. One of them, of my patient, was in my ward, who was a senior executive in a company. And while I was talking to him, he sounded dull, and I asked him, "What do you do for when you take a break?" And he told me, he says, "I go to Chowpatty and sit there." And my VR team, augmented reality, created a entire augmented reality spectrum with mixed reality options for this person, as though he was sitting in Chapati. For that 5 minutes, I could see the joy in his face, as though he had forgotten where he was in HCG Bengaluru and transported himself to Chapati, sitting in the shores, listening to the waves. And I thought, well accomplished at minimal cost. Or a person who wanted to do bungee jumping, and they created one from Burj Al Arab for him, and he's jumping out of there, and he's actually thinking that actually sitting in my ward, he was experiencing a jump and feeling the exhilaration of thing which I thought releases endorphins and healing. So I think somewhere in this path, technology will come closer to you faster than what you can even imagine. So we're not talking decades. We're going to talk days, weeks, months. I think in the coming time.
That's fantastic. Dr. Vishal, I want to ask you about integrative therapies and also now, as you had mentioned, the world is moving more to patient centricity, involving the patient in their cancer journey, educating them, empowering them, and also implementing various integrative therapies like personalized nutrition, physical therapy, psychological guidance and help and evaluation for patients who are going through treatment. They're calling nutrition the additional pillar of treating cancer today. So, can you tell me how important integrative therapies have been for your patient? How important, from a scientific point of view, how important does a role nutrition play in your patients responding to treatment adherence, and also quality of life?
I think globally it's a well acknowledged fact that you need to create a balance for IQ, EQ, and SQ, your intelligent quotient, your emotional quotient, and your spiritual quotient. And I think that kind of summarizes a being, the mind, body, and the soul. Now, it is essential that while we take focus on a small aspect of the cancer cells, be it 5% to 10% in a advanced stage cancer patient to 90%, which is the good cells. We never talk about these 90%. We are all busy killing the 5 to 10%. And always the debate is around the 5 to 10%. But somewhere there is an assumption that वो 90% will handle them on their own. वो अपने आप में संभाल लेंगे. They'll manage on their own. Nobody has actually spoken about how do we take care of these 90 while we are dealing with the 10. And I think that's a lost conversation today, which needs to be brought in. And in this, food is the new medicine. I think I would summarize and simply say that if you look at the science of cancer from 1929, when Otto Warburg got his Nobel Prize for saying sugar contributes to the growth in cancer, we today know nutrition has a pivotal role to play. And I would segregate diet from nutrition and say diet is one aspect of our element, which is also connected with the satiety satisfaction center of the brain. Nutrition is an aspect which talks about how we can look at immune checkpoints to be dealt with using high protein, high fiber, balanced fats, moderate amount of sugars or low sugars, and vitamins, minerals added with multiple colors in your plate to deliver the best nutritional value to enhance your immune system, which is often forgotten in the busy schedule of killing, eliminating, and kind of treating the tumor. So I think time has come back to bring it onto the table to talk about a holistic, integrated approach, a complete 360 approach, where the patient centricity is going to be discussed in a much more holistic manner, which includes his quality of life, which caters to his palate, which caters to all aspects of cancer, not just the cancer cells itself.
True. Um, and Dr. Vishal, a question that I'm asking everyone because it's something that we all are battling in India and globally is firstly, or let's just speak about India. I mean, there is a very large percentage of the population that will indulge in alternative therapies. I mean, we've had this conversation before. And while Ayurveda and natural medicine is great in its own right, it can also be harmful in certain circumstances. Now, how does a patient, because they have this negative connotation towards treatment, what we have noticed is as soon as a patient is feeling better, they drop out of treatment or there's low adherence on sticking to the treatment regimen, and then they think that no, I'll do some alternative medicine because it sounds natural and that will be better for me. And this is something as a doctor you probably are facing on an everyday basis, especially in a country like India. How do you deal with that? How do you deal with high risk of non-adherence with your patients, if there is? And what can we do to change that perception for patients?
So I think Samara, we've, like you rightly said, we've discussed this dime and dozen time before, debating on all aspects of this. and let's take a common ground of mutual respect to all specialities and
Yeah.
say that if we were to take this on a common platform, there would be two words. One is integrated and the other is communication. Now, when I say integrated, we in somewhere need to adopt the approach that integrated medicine would look at bringing stakeholders on a common platform of science. And the aspect of communication, I always encourage my patients not to hide these information from me because that has strong implications to my planning of his treatment. And I think in this way, what I encourage many of the times to patient is to connect me with their alternative medicine practitioner or an Ayush practitioner and have a good dialogue to tell them on their science, because by legalities they are permitted to practice their science,
Of course.
and by my legalities I am allowed to practice my science. Both of the science do not give any specific indications to deter one from the other, but here an informed decision is needed to be arrived at by the patient to make a more planned evolution of his outcomes. So it is very essential for patients to get and engage the parties into a dialogue to come to a common point rather than keeping either sides in the dark, hoping that he will benefit the maximum from this. And I think that could be a good starting point to engage in. And then also take a more calculated, informed decision based on his own understanding of each of these sciences. I have seen successes on both sides, I have seen failures on both sides, and I'm saying that today, allopathy has reached this area because of a systematic evidence based approach and not an eminence based approach. So, empirical medicine, eminence based medicine is not to be practiced in today's era of evidence based medicine. I think that's something which is very clear across all sciences, that we need to produce evidence. And if somebody is able to show some evidence that it enhances the immune system, it is a good food supplement, it is a good nutritive addition, or it is a good alternative medicine target, I think that is a good conversation to initiate more amount of work. Many of the times, the biggest molecules we've discovered in allopathy are actually finding its roots in Ayurveda. And food is by itself a medicine. So I think we are talking about two aspects which are the same, which are the two sides of the same coin, but need to have better integration and communication.
I think it has to be a very strong marriage of allopathic treatment and alternative, and actually keep it complementary, right? Instead of it being two different schools of thought, because it does not have to be that. So you're absolutely right. I wanted to quickly ask you a little bit about data, right? And about how important non clinical aspects of data are becoming for understanding, or improving patient outcomes. So, example is today we're again moving into a world of technology and medical advancements, and using technology to a large extent, which we spoke about, and which retrieves a lot of clinical data and medical data of a patient. But what about the other aspects of data, like behavioral sets of data, psychosocial sets of data, the qualitative sets of data, which where a patient tells you how they're feeling, as opposed to just a quantitative measure that is completely related to their medical condition. What are your thoughts on that, on the non-clinical aspects, and how that's actually making your decision as an oncologist to provide more precision or precise medicine and treatment for your patients?
So, Samara, I think both clinical and non clinical complement each other here. And I strongly believe that today non clinical data is equally relevant. So WHO, for example, has a distress thermometer which talks about the physical aspects, the mental aspects, the financial aspects, the social aspects of a person's being, which gives a fair assessment to understand and help you assess before the patient walks into you to know what is the level of distress he comes with, which is beyond the disease, beyond your TNM stage. So a lot of this could actually help you in terms of putting a more focused efforts towards treatment in terms of elevating his mental, physical, social, and psychological sufferings or debilities which he is facing, which he may not open to you in a small few minutes of your conversation in consultations. So it's equally important to give emphasis towards a medical social worker's jobs to create such a profile for each of these patients and plan and kind of present this in a more articulate manner. No data point in a patient's life, when I say cross sectionally or longitudinally, is irrelevant. No data, because each one of these data point is somewhere bringing you to a new learning and evolution to maybe give a new discovery. The collection of this data and the data reliability has been the factor, and us investing in data collection.
True. And Dr. Vishal, one thing I do want to speak to you about is the trial, the smaller trial that we did using integrative therapies along with your patients to measure quality of life and various parameters in terms of their nutritional status, physical and psychological. What are some of the thoughts about that? What did you experience as a medical doctor to see how your patients were actually improving over that time frame? And was there any kind of feedback from your patients that negative or positive about incorporating these therapies into their treatment regimen?
See, I think one of the most important learnings for me was that when you presented this data to us, there was a lot of good science of collation of data. You all collated the efforts done, the patient's feedbacks, or their overall objective improvements, and naturally their choices. So what I realized was a lot of them wanted more choices. Many of them asked us to give us more emphasis on programs like this that would actually give them a lot of personalized care at homes in their areas, which I think was very relevant. And most importantly and distinctly, what I remember is of one patient among all of those patients. I don't remember many of them, but I think that one patient who kind of really, I think, gave affirmation to my thinking was me and Dr. Shekhar Patil were actually treating a patient who had an early voice box cancer. Early, when I'm saying it was locally advanced, stage 3, but something that would not require a major surgery. This patient, however, required chemo with radiation. And considering his multiple comorbidities, hypertension, cardiac disease, sugars, and arthritis, and various issues, he actually, Dr. Patil told me, Vishal, I think it's better we withhold the chemo. I don't know whether he'll be able to sustain it, but that would reduce his chances of cure by one third. And that was a discussion that we did with that family, and we told them about how important we could look at working towards this with their consent, involving a proper integrated approach to a holistic nutrition, diet, meditation, yoga, everything, etc., etc., and all of this which you all I think I've bundled up. And the family was agreeing to take this risk on a more informed decision and said that we will take up a comprehensive approach and we will go with the risk. And Dr. Patil also walked an extra mile and said that if they are willing, I'll also start and see how he tolerates, and then we can abruptly stop, but we'll go weekly and we'll reassess. I remember the 6 weeks that he went on without a stop for me was a genuine, I would say, endorsement of the fact that we were able to make it to the finish line in a meaningful way. And even today, when he walks into an OPD with his arthritis, limping, but I feel happy, and I said, we optimized cure and care together, and that I think is achievable through a joint holistic approach by which you add value to a person's overall holistic treatment and reverse some of the aspects which earlier we thought we would not be able to deal with. Now, this needs a more focused factory approach, a more dedicated approach where we build these kind of ecosystems and we are able to kind of cater to the patients in a more controlled manner in each of these complicated scenarios. Each one, I think, is a unique case study. I remember one of my patients coming and asking me, "Why don't you all offer past life regressions?" And I said, "Oh, wow." I said, "That's something that I've been talking about and reading with Brian Weiss and seeing all of this work. And I had talked to a lot of hypnotherapists about what do they feel about their science in a more open way. And I'm not saying I'm an advocate of this, but I'm saying I'm an advocate of science, and I'm open to discussion, and I'm open to more debates and discussions. And I would also want to keep a ear on my ground on what my patients want. What is it that they're looking for, and what are the answers they are kind of looking for? So this, I think, journey has helped me open up my understanding into this area of things which are very simple, sometimes at no cost or low cost, and very meaningful to add life into patients' years. It's a lot of meaningful evolution there.
Yes, absolutely. Dr. Vishal, I've taken a lot of your time, but I'm not going to let you go without you answering one very, very exciting question for me personally, and I'm sure everyone would be interested, just considering the type of person and doctor you are. What is the latest, most exciting, innovative, thing that you're working on right now, if you can say?
So I'm working on many innovations, working with the support of the state and the union government. I'm working on various inventions. I think the moonshot that I'm currently working on is we recently published a paper which talks about physics in cancer.
Okay.
And this paper just recently got published. But my moonshot was, can we pick up the cancer at stage -1? Not stage zero. Stage zero is pre-malignant, but stage -1 is if you can pick it up at electron level. So this paper actually alludes to the role of pure organic chemistry and physics, and its role in cancer planning and detection. Because I somewhere believe, I'm sorry, but that biologists have been ruling this world for too long. And it's also time to create a little space for people with chemistry and with the physics background and possibly mathematics. And now I'm a member of the Mathematical Oncology Society, and globally working towards some very innovative solutions where we feel that the fundamentals of biology are answered by chemistry, whose answers lie hidden in physics and mathematics. And quantum physics also has a lot of role to play in this, especially quantum tunneling, to look at how cancer metastasis happens. And I'm hopefully planning, hopefully a few years from now, to look at, can we build a CT scanner like a frisking machine that could actually pick up these cancers at stage -1 to a certain predictable level. And the paper, which is now internationally accepted in an index journal, actually alludes to this topic of how we could reach here through an electron tunneling mechanism.
Wow.
Very logical, but I mean, it's a moonshot, but I thought you need to dream to reach there, and then work towards it. So worth making an effort towards studying and seeing. Imagine if I want to know 10 years from now, will I develop cancer? And if somebody can tell me, yes, your left lower lung is vulnerable, I think we have a starting point towards working in prevention.
Wow. Absolutely. That will change the world. But we know that you are always doing these phenomenal things. Thank you so much, Dr. Vishal. Thank you
Thank
so much
you.
for your time. And I will be in touch as usual with you. So thank you so much.
Such a pleasure. Thank you. Thank you, Samara.
We hope you enjoyed this episode and found it useful for yourself. For more such episodes, please subscribe to our YouTube channel, Apple Podcasts, Spotify, and Log Media website, where we dive deeper into the world of integrative oncology and healing cancer the right way.